Well, Lenny, as you know, we're real advocates of intraoperative audiometry. That's sort of a tongue twister, so I think for the purposes of our discussion today, let's just call it IA. And this necessitates the patient being done under local anesthesia. In another segment, we're going to talk about how we give our local anesthesia. We use a portable audiometer with a sleeve, a sterile sleeve, and with an earphone. Before we start the surgery, the circulating nurse will test the hearing at 1 or 2 frequencies, usually 500 and 1,000 hertz, and she'll go from louder to softer. And it's interesting that that result that she gets in the operating room is extremely similar. It's within 5 decibels of what we had in a soundproof room. In a routine stapedectomy, we test the preoperative air, and let's say it's at 65, and the bone is at 25. And following the surgery, we test again, and we're now at 30, or 35 or 40. In other words, there's been a good increase. We're trying to get within 20 decibels of the preoperative bone. It's a qualitative test, not a quantitative test, and it's going to take a minute altogether. So in this particular case, we're happy with where the hearing is, and we're able to tell the patient everything is fine, and we tell the family the same thing. We're done. Let's take the same patient with a air of 60 or 65 and a bone of 25. We do the surgery, we test the hearing, and the hearing hasn't changed. This happens in a fair number of patients, as you know. Now, we would then look at our prosthesis. Again, we use a self-centering prosthesis, so there's not much looking around to do. And we would terminate the procedure. We would then tell the family that the operation was not successful, that we think that this is a matter of having a cochlear otosclerosis or something in the inner ear interfering with the hearing. And further surgery is not going to help, and we did not help him in this procedure. Let's say we didn't do the IA. What would happen was that this patient would have another procedure 2 months or 6 months later. Because in this case, when the packing is removed, the hearing is no better, and the physician feels that the prosthesis slipped or moved or something of that sort. So he has a revision procedure. And heavens knows how many patients we see who have had one procedure done in town, the second procedure done at the university, and then for the third procedure they're sent to us. Well, the hearing didn't improve the first time with a good operator. It didn't improve the second time with a good operator. We're not going to do the third one because probably this patient has a cochlear otosclerosis, and you're just going to go on and on doing more surgeries. A great example of that was a number of years ago in the otosclerosis study group with experienced surgeons. A surgeon presented a case that he had done, and the hearing wasn't any better. He looked back in and there were adhesions. Now, we don't believe, do we, that adhesions cause a conductive loss, but he removed the adhesions, and that was all he did, and the patient was no better. So he did a third procedure. Again, he found adhesions, and the hearing was no better. And now the case was being presented to the group on what to do next. Well, I knew what to do next. Do nothing. And if they had done IA, they would have known after the first procedure there's no use doing a second and third procedure. Lenny, how about the patient where we get in the ear and the footplate is blue?
Well, we may have a mobilized footplate, which can happen to all of us during the dissection or palpating the superstructure. So I think the IA is extremely valuable. We can place the eardrum back and do our intraoperative audiometry. If the hearing improves, we know we have a mobilized footplate. If it's a thin footplate, we know the chances of it refixing are very low. If the patient had a mobile footplate and perhaps did not have otosclerosis, then we avoid an unnecessary surgery with the hearing not improving, considering the intraoperative findings.
Exactly. And then let's take the patient where, so there could be 2 ramifications there. One is if the footplate is moving and the hearing has improved, then we've inadvertently done a stapes mobilization and we can take it from there. If, on the other hand, the foot plate is moving and the hearing did not improve, then this patient does not have otosclerosis, so we would certainly terminate the procedure. Now, I know in your reconstructive work in chronic ear that you're using the IA just like we're using it in stapes work. And I know it probably helps you even more there, or at least as much as it does in stapedectomy. And then we'll discuss revisions. But how about in your chronic ear work?
It's been very valuable in a number of cases. Recently I had a case where a patient had a partial ossiculoplasty in the past, and they now had what appeared to be a canal stenosis. And I explored the ear and took down the bony regrowth which had occurred lateral to the partial ossiculoplasty, saw cartilage reconstruction with a probable prosthesis underneath that, and prior to disturbing that, laid back the drum and did intraoperative testing, and the hearing was almost up to the bone level. So in that particular case, it avoided additional unnecessary surgery and trying to revise a prosthesis which was scarred down. Similar to your revision stapedectomy approach.
Right. Well, how about your selection of prostheses? I know sometimes you'll do with a bad incus, you'll go ahead and put in a modified Robinson prosthesis or a Lippy prosthesis, and sometimes you'll go to a total. Doesn't the IA help you there?
It's very valuable. We're not fortunate enough to have a healthy superstructure in every case in chronic ear disease, so I will try to use a partial. We know that generally we have better results with a partial ossiculoplasty, but if there is no improvement or I don't have proper contact to the foot plate, I might laser off the superstructure and put a total ossiculoprosthesis and then repeat the testing. And that's happened to me on a number of occasions.
So it actually helps in the selection of your prosthesis.
As well.
Yeah, of course, in revision stapedectomy, it's great because, first of all, you better be doing that patient under local, because if you're removing another prosthesis and the patient is dizzy, if the patient is asleep, you're not going to know the patient is dizzy. But there are also several options now in where you're going to place your new prosthesis in a revision case. Again, whether you're going to do a total reconstruction, a TORP, or exactly what you are going to do. Also, the length of the prosthesis can vary, so it's important there to know what your hearing is. So, in summary, we totally believe in IA. It's going to add 30 seconds or a minute to your case. You're going to know at the end what the hearing is. You're going to know if you have a success or a failure. You're going to know where to place the prosthesis, and you're going to know which prosthesis to place. So we're strong advocates of the testing.
I'd like to show the setup that we use in the operating room.
Okay.
As you mentioned, you don't need an audiologist in the operating room. Your circulator can learn how to do this in about 5 minutes, and I've done this in a number of hospitals and surgery centers. And this goes inside an orthopedic sleeve, so it is sterile, and it's used as it is prior to the induction of sedation, and then we'll use a graded response with the audiometer for determining the accurate level at the end of the surgery.